Good evening, everyone. Welcome to the second part of the 17th Masterclass of Jaipur Surgical Tutorial, which is on corrosive esophageal injury. For those who are joining or who will be watching our masterclasses for the first time, this is an extension of Jaipur Surgical Tutorial, which is an online education portal which we started more than 3 years ago at the Mahatma Gandhi Medical College and Hospital, which is a part of the Mahatma Gandhi University of Medical Sciences and Technology. The Jaipur Surgical Tutorial is coordinated by my colleague, Dr. Anand Nagar, who is a professor of HPB surgery at my institution. In between the sessions, I will be projecting a slide which will give you information about as to how you can join Jaipur Surgical Tutorial. You just have to send a WhatsApp message to Dr. Anand. He will add you to the group, and then you will start receiving information about all the educational activities. So under the JST, we conduct a session every Saturday, 9 a.m. to 10 a.m. India time, where students present cases. They also present operative procedures, and the faculty moderates, which is like a preparatory session for your exit exam. And then for last 1.5 years, we've been conducting these master classes, which are done last Wednesday and Thursday of the month, 7 p.m. to 9 p.m. both days, where we select a topic, and then we gather a panel of experts for moderating and for presenting, and there is a half an hour open house session. After the session, in between, I would announce that how you can receive more information, more reading material on the topic, where I send complimentary soft copies of the chapters from my books related to this. So if you send me a mail at vkkapoor.india@gmail.com, write esophagus in the subject of the mail. So within a week, all the mails that I receive, I will send you the chapters on clinical surgery and operative surgery related to esophagus, which would cover both esophageal cancer and benign diseases, including corrosive injury. So for this topic, I have requested two of my colleagues, Dr. N.R. Dash, who's a professor of surgical gastroenterology at the All India Institute of Medical Sciences in New Delhi, and Dr. Vikas Gupta, who was earlier professor of surgical gastroenterology at the PGI Chandigarh, and who's currently in the National New Medical Center, Abu Dhabi in UAE, to moderate the session. So with that brief introduction about JST and the master classes, I hand over to Dr. Dash and Dr. Vikas to moderate the session. Dash.
Good evening, sir. Good evening, Vikas. And good evening to all who are watching this. We'll be watching later on.
So I think yesterday we have elaborately discussed about the acute part of the injury. So now, endoscopy plays a very important role in determining and managing these patients after the acute insult is over. It helps in identifying the strictures, and many of the strictures can be managed endoscopically. And to discuss about the endoscopic management, I will request Dr. Anurag Govil, who is a gastroenterologist at Santokba Memorial Hospital at Jaipur, to speak on the endoscopic management of corrosive injury. Over to you, Dr. Anurag, please.
Yeah, thank you so much.
Before Dr. Anurag starts, let me add, Dr. Anurag is one of the senior most and most experienced and most skilled gastroenterologist and endoscopist in the city of Jaipur. He is working at one of the oldest and most prestigious hospitals, the Santokba Durlabji Hospital in Jaipur, and he's the chief of the Santokba Institute of Gastroenterology. Anurag, please.
Well, thank you, sir. In fact, thank you so much, sir, for this very prestigious opportunity that you have given me to be able to talk on corrosive strictures of the esophagus, the endoscopic management. And this indeed is prestigious. So Dr. Dash has already set up the base and makes my topic easier to discuss. Coming to the first slide. So now, before we go on to discuss the endoscopic management of corrosive strictures, most of it actually entails dilatations, which means taking care of the strictures, and very rarely we do come across some complications which can be handled endoscopically in form of fistulas and bleeds. But I would largely be focusing on the management of corrosive strictures of the esophagus. And before we get down to start dilating these strictures, I always tend to gather a lot of background information before we actually do it. I personally evaluate them before doing the first endoscopy in form of a routine biochemistry and X-ray chest. The reason being that these are patients who come to us with malnutrition, who come with recurrent aspirations, and so I surely don't want to dilate them with ongoing consolidation, recurrent aspiration pneumonitis, and so on. The second study that I'm very happy doing is any form of oral contrast study, whether it be a barium or a gastrographin study, or maybe even a contrast CT. Then the whole purpose is I want to define the stricture well. How many are they? What is the length? Whether it is simple or complex. I'll come to simple and complex. But I would be very happy defining the complete stricture, the complete length of the esophagus before I start dilating. Of course, there is a caveat, a catch here. There is a tight proximal stricture. The dye doesn't go beyond that stricture so well. And we just might overestimate the severity of stricture because of less dye reaching the. At the same time, if the dye can give us some information about the stomach capacity, that also goes a long way to help us in deciding which dilator to use for the esophagus. CT scan largely is required only for complications if anticipated in form of either fistulas, if the patient has recurrent pneumonias or recurrent aspirations, or if the patient has had a lot of sentinel bleeds, then also I'm a little more comfortable checking the CT before I go ahead and dilate. I don't want to dilate and land up with a massive bleed. After having done this background, it's easy to say whether the stricture of the esophagus. Now, this distribution is actually for any stricture, any benign stricture, but it holds well for corrosives. So the stricture could well be simple or complex. The simple being very focal strictures, less than 2 centimeters straight, and it allows the endoscope to go through. The complex, of course, on the other hand, are long, tortuous, and they were very severely compromised lumen. It's good to know what the stricture is all about because that helps you plan your further course. So having done that, I tend to record, preferably in a diagrammatic representation on my sheet, the distance of the most proximal stricture from the incisors, whether it is simple or complex and why, of course, and whether there are any diverticulae or ulcerations. But that also helps me decide when to dilate and how far to go. The stomach, whatever details that are available, should also be noted. We don't want to land up, dilating the stomach after you've done the esophagus. It's good to tell the patient that we just might have to handle the stomach also at a later date after having dilated the esophagus. This background information helps me, one, predict and plan. So one, I can kind of predict the response. There are various studies. I've just picked up two. So there's one which says that if you have young adults, if you have caustic strictures, and the stricture numbers are more than 2, with of course they being complex, then they will probably require a lot of sessions of dilatation. There's another study. Dr. Brewer from GV Pant has done a lot of study on corrosives. He's published extensively on corrosives. And what he said in his study was, I was in fact part of collecting this data with him. I was a DM student then, is that the age, sex, grade of dysphagia and site, it really doesn't influence as much as it is the thickness of the esophageal wall. If you do a CT and the wall thickness is more than 9 millimeters, then this patient would require a significant more number of dilatations compared to the others. With this information, I can plan and also plan at the same time how best I will maintain the nutrition for the anticipated number of dilatations. This could go on for months and years. So I have to be very sure that I have to maintain the nutrition. Do I need a feeding jejunostomy? And when do I start dilating these patients? Before the first dilatation happens, a very, very important part of this program is to counsel the patient. Here is a disease which is not easy to manage. Here is a disease which will require multiple visits to the hospital. And therefore, we have to counsel these patients very adequately. Tell them the expected course. Give them the cost. They should be made aware of the results of the dilatation and especially the risk, which is perforation, because the perforation could be actually detrimental and lethal for the patient. Also, like I just mentioned, that if at all there is anticipated stricturing or reduced capacity of the stomach or antral stricture, then whether we will need endoscopic management or surgical management of this patient later on, that also has to be told to the patient. And I tend to tell my patients that why we are choosing on dilatations and not surgery, when I tell them a little in details about the extensive surgery that it requires and also the need of maybe dilatation even after the surgery because of an anastomotic stricture. So once the patient is very sure that he wants to go on an endoscopic dilatation, that's when the dilatation starts. The endoscopic treatment for corrosive stricture esophagus, of course, first is dilatation. And we have these various dilators. I'll very, very briefly discuss about them in the next slide. So if we are able to dilate, then I go ahead and keep dilating them as and when required. But if the first dilatation fails, then there are two possibilities. One is, of course, injecting intralesional steroids even before the first dilatation. And there's a round the way approach which I've never used, but you go through the stomach, make an incision, take help of surgeons, go through the stomach, approach the esophagus in the retrograde fashion, and try and dilate. Of course, if these strictures are refractory or recurrent, and in a short while I'll tell you what is refractory and recurrent, then we have various other modalities in form of intralesional steroids or mitomycin C, even incisional therapy, and last of all, stents for these very refractory and recurrent strictures. Now, just to get this terminology right, refractory are the ones which I find dilating these patients at a 2-weekly interval. I've done about 5 sessions, so that's about 10 weeks, and I've not reached even 14 millimeters. So that's what it's called refractory. And recurrent is where we've been able to dilate them well. We've reached even up to 15, but the lumen diameter does not last even 4 weeks. And they keep coming back to you, and that's when it is called a recurrent stricture. So while I'm discussing the dilatation, it will be briefly on the instruments, the protocol, how much to dilate, and what are the results. Now, these are the 3 most common instruments used for dilatation. The top one is a polyvinyl Savary-Gillard, as it is called, dilator. Second is a metal steel olive. And third is the balloon, the through the scope TTS balloon. Well, these 3 are the most extensively used. And coming to just a brief about these, we have these Savary-Gillard dilators from 5 to 20 millimeters. The good part of these Savary-Gillard dilators are they have a very good taper, so it's easy to dilate. The long nose actually helps in gradually dilating the stricture. But the bad part of this long nose is that if you have a strictured stomach, it will not accommodate the long nose, and that's where you will face the problems. And so if this is a strictured stomach, a low capacity stomach, you have these Eder Pesto EP olives, as they're called, steel, and therefore they're very good for tough strictures. The nose is small. So if you have a contracted stomach and a very tough stricture, that's where these olives come into play. All departments, I would suggest, who are into deeply dilating these corrosive strictures should actually have all 3 of them. Oh, I'm sorry. I missed out on the balloon, the previous slide. I'm sorry. Just a second. Yeah. So the balloons are good for very, very tight, narrow strictures. Even the smallest of the Savary or the olive doesn't go through. Then you can pass a balloon over the guide wire and then dilate the balloon, which leads to a radial force and without the shearing longitudinal force that the others have, which is a theoretical advantage. Also, one good thing about the balloon is it is done under direct visualization. But the worst part is that there is no tactile feel. With the other dilators, you know how much force you are using. Here, when you're dilating with a balloon, you just inflate it to the maximum size. Now, whether the stricture dilates or the stricture perforates is largely on the balloon size and not really so much on your tactile sense. I've just brought this slide for completeness. This is a bougie cap by Ovesco. I have not used it myself, but looks interesting. There's this transparent cap in front of the endoscope. It goes over the guide wire, and you actually land up dilating these strictures under vision with the scope. I have not used it, and I'm not very sure if these tough strictures due to corrosives would be very, very comfortable dilating with this. Maybe For the others, yes. I couldn't find a specific report of this dilator being used for corrosives though. Now, what is the protocol that we use while dilating? How much should we do in one go? So this rule of three, which has been described way back, about 2 to 3 decades back, very widely followed. We also do the same. It is basically based on blind Buginoids that was done that time. And they used to do it just beyond 3 millimeters of the first bougie which experienced resistance. However, over the years, this rule of three has failed to demonstrate much benefit. The only place where this rule of three should be very, very strictly followed is malignant strictures. They are the ones if you tend to dilate more, they leak very often. But at least in corrosives, we can go beyond 3 millimeters of the first dilatation that you do that day. And I quote one study where there was 297 complex strictures and they were dilated without adherence to the rule of three. And there was no high rate of complication. So I leave it at that because much depends on the experience of the endoscopist who can go beyond 3 millimeters of the first dilatation that he used on that particular day. Now, how frequently and how far do we go? Well, literature says every 2 weeks to even every week. We at our department follow a weekly protocol for the corrosives because they tend to become very narrow by the end of 2 weeks. So it's somewhere between 1 and 2 weeks. But yes, of course, no one is wrong if they're doing it at 1 week or at 2 weeks. There is an arbitrary assumption that we should go up to 15 millimeters maximum in corrosives. It is supported by the British Society of Gastroenterologists. What happens if you dilate more, at least in corrosives, there is not enough data. But for GERD strictures, it is well documented that if you go up to 18 millimeters, the recurrence is less. So we also in our department usually go up to 15 and rarely go up to more than 15, which is 16 or 17, if there are very frequent recurrences. The choice of instrument, what do you use? This is largely operator dependent. And there is one meta-analysis, 5 randomized controlled trials, and they have definitely without doubt shown that both bougie and balloon have equal efficacy and equal complications. And so what you have and what you have been using is what decides what you should use. The results of these dilatations, well, 10% remain refractory, 30 to 40% come back with recurrences, and 10% need very prolonged dilatation. There is this study of 123 adults, and Dr. Brewer published this study in Gut, very elegant study, which I always quote this study, that if we use this rule of 5 dilatations and then call it a refractory stricture, probably most corrosives will fall in the refractory range. He has shown on a more than 3 year follow-up that the recurrence rate significantly drops only after 1 year of weekly to 2 weekly dilatations. And it is after 36 months that the recurrence rate becomes comparable to peptic strictures. The studies, of course, have reported very varying number of surgeries that the patients actually land up with, from 2 to 3% to even up to 50% on long-term follow-up. The complications of dilatation, perforation, that's the most dreaded complication. I have purposely put up studies which have reported higher complications so that, you don't take it lightly. And there are these 2 studies, again, one from Dr. Brewer, where he showed that in 51 patients who were kept on long-term dilatation for even up to more than 1 year, there were 8 incidences of perforation, and that's quite a bit. There's a study from Korea. This supports, of course, a very high perforation rate with balloons, and that's up to 30%. But most studies tend to say that the percentage of perforation is less than 1%. The other complications while dilating are bleed and aspirations. Bleed and aspiration both usually do not need any endoscopic intervention. What happens when you fail to dilate in the first go? There is this very large series of 340 patients, and I fail to understand how they got 340 patients wherein they could not even go in the first go. But so it says that if you're not able to dilate, come out, inject corticosteroid at the site of maximum resistance and repeat the dilatation 2 weeks later. The first dilatation would happen then In most, that is up to 75%. I'm not touching on the round-the-way approach because that's something very, very exhaustive that one would do. One would probably take up surgery rather than, incising the stomach and going retrograde into the esophagus and tend to dilate the esophagus without the results being very sure. So I'm not touching much on this round-the-way approach, which at least I have never used. Coming to refractory or the recurrent strictures, we have these options. One is intralesional steroid injection. Very heterogeneous results, multiple small studies. I quote one, which was a randomized double-blind, placebo-controlled trial. You give 4-quadrant injections, 0.5 ml each of the steroid. Maximum, of course, is 80 milligram. And what they showed was that there was significantly less need for repeat dilatation in the steroid group. That is 13% only compared to the 60% which happens in refractory or recurrent strictures if you don't inject steroids, which is triamcinolone local. The benefit is evident in all benign strictures, especially in the reflux and asthmatic, but also specifically in corrosive. One modality that we also tend to use quite often with appreciable results. There are reports of using mitomycin C instead of steroids, again for the same reasons, antifibrinolytic properties. And this pediatric study of 20 patients, they applied topically 0.4 milligram per ml, again reported a significant improvement in the number and frequency of dilatation required. Eventually, if you use them and the dilatation number and frequency goes down, that saves a lot of cost on part of the patient. And what is best is that both of these can be combined with other modalities, whether it be electrocission that we do for refractory or recurrent, or even stents. Electrocission is an endoscopic minor surgery. And what we here do is that at the site of, if the stricture is small, one, it has to be a small stricture, kind of almost like a diaphragmatic stricture, and up to 1 to 2 centimeters, we make linear incisions with a needle knife using the electrocautery on 4 quadrants. And having done that, we either leave it at that or put in a stent. It is a very useful adjunct to dilatation, though of course it is technically challenging. I have personally used it only once in a corrosive stricture without good result. However, I don't say that the technique is bad because I did not have a good result, primarily maybe because of less experience in using it in corrosive strictures. This is a technique very commonly used for in asthmatic strictures though. Last of all, if electrocission also doesn't help, we have stents. And as I said, 10% remain refractory. We have 3 kinds of stents: self-expanding metallic stents. You also have self-expanding plastic stents, and lately biodegradable stents, like the ones that are available for the coronaries, are also available for the esophagus and also for the biliary tract. Now, these 3 stents, again, any one of these 3 can be used. Not much comparative analysis available, but what I could find is that the technical success of placing these stents is 98%. Placing these stents is easy actually. And this comparative analysis suggested that the metallic stent fared the best, giving 40% long-term relief. The biodegradable one had 30%, and these biodegradable ones usually dissolve by the end of 3 months. The plastic stent, of course, had the least appreciable results, which was only 10%. Problem with these stents is, though of course you're supposed to remove them from any time between 1 month, that is 4 weeks to 12 weeks, is that there is a lot of tissue overgrowth because of irritation of the stent margins in the esophagus. So the healthy tissue of the esophagus actually covers the margins of the stent. That's a protective phenomenon which the body follows. And that makes retrieving these stents difficult. So if you forget them for long or they left more than 3 months, then retrieving these stents might become an issue because of tissue overgrowth, which is the highest in plastic and the least in biodegradable. But I would end up with stents saying that till date, there is no ideal stent. The migration rate is very high, 30%, and that's a fair migration rate, with an overall clinical success being only 40%. It has to be removed before 12 weeks and should always be a last resort. But even if this last resort helps in 40% of the refractory strictures or the recurrent strictures, then why not? In the end, I present a treatment algorithm. This is actually for benign esophageal strictures, also includes corrosives, but our own experience and the experience at GB Pant is that most of corrosives will qualify, go beyond what is said here, and therefore we continue to dilate them despite them being called refractory or recurrent. So you dilate them with either bougie or balloon, go up to 15 to 18. If within 5 sessions at weekly or twice weekly intervals, you don't move ahead, then you combine these dilatations with intralesional steroid injections. If 3 sessions of steroids don't help, then you go ahead and use incisional therapy. And again, they have to be short strictures. And again, if 3 sessions of incisional therapy don't help, go ahead and put in a stent. And if that also doesn't help, then of course, you have to fall back on the surgeons like any other endoscopic therapeutic maneuver that we do. Thank you so much, sir.
Thank you, Dr. Anurag, for extensively elaborating on the endoscopic management. I think we will have discussion in the end when we have final question and answer round session.